Hello everyone. Today I'm going to discuss about the management of hyperkalemia. So in ICU daily practice we see many patients with hyperkalemia. The first thing we should discuss I think is the causes. Most of these patients we see are from acute kidney injury and chronic kidney injury. Some of them I have seen with the rhabdomyolysis, and other causes also include intake, and some are drug induced. These are some basic causes that we find. Now the next thing is how we can interpret in ICUs or in emergency that the patient came with hyperkalemia. The symptoms are only shown when it's very critical, and they usually involve like bradycardia or palpitations and muscle weakness. These are some symptoms that we see in patients, and in severe cases the patient also, there is a decrease in consciousness as well. So if the patient come in emergency condition first time, so how we can interpret? The first thing we have to see is the monitor, so we can take out an ECG. Now in basic ECG what we find, the firstly it's in stepwise process. Now the first thing we have to see is the T wave, which is a tall T wave, or and the next thing is what we can see is white QRS, and the third thing is the sine wave pattern, and fourth is asystole. This mainly affect our cardiac membranes and result in fatal condition, even death. Now the pattern that I told you, like the tall T wave, wide QRS complex, sine wave pattern, and lastly the asystole, this represent the severity of hyperkalemia. So if the patient came for and you suspect the patient is hyperkalemia, now comes the management part. How to manage it? The first thing we will do is to stabilize the cardiac membrane. For that we have to use the 10% calcium gluconate in 10 cc over 5 to 10 minutes. This is the first step that we have to do to manage the hyperkalemia. Now the other thing we used to do in ICU is there is a shifting of serum potassium to the intracellular inside the cell. So how we can do is we can use the combination of insulin, about 6 to 10 units according to the pathology, and in combination with dextrose to prevent hypoglycemia. We also need to check for the random blood sugar of the patient. And the second thing is the nebulization of salbutamol. We will use the 2 respules and we nebulize the patient. And the third thing is what we can find out is acidosis. If there is metabolic acidosis induced by hyperkalemia, we can also use sodium bicarbonate to stabilize it. Now the last thing what we can do is to shift out of the body the serum potassium. Now this thing can be done by basically first is loop diuretics. We can use like furosemide, and according to pathology we can adjust the dose. And the second thing we can use is potassium binders. These are mostly we use in mild to moderate hyperkalemia. These are oral potassium binders that we use in moderate conditions. And the third thing, which is the most effective, is hemodialysis. This is usually we use in those patients who have like resistant hyperkalemia, in patients of chronic kidney disease, rhabdomyolysis. In these kind of patients, we usually prefer to do hemodialysis. This is only done in the severe cases, and the rest of the pattern that I have told you, we have to follow it. Like first we use calcium gluconate. First we have to stabilize the membrane. The second, we have to shift the potassium from extracellular to intracellular. And the third is we can flush out the potassium. So thank you everyone, and I hope you like this video.